So the next hour or so, I will have to reduce it to an hour, we'll be focusing on assessing the quality. And I will walk you through these individual criteria that I mentioned earlier. Just remember our general evidence hierarchy, and this is to remind you that this evidence assessment and moving from evidence to a recommendation is really a gray box when it comes to the evidence assessment. I mentioned these examples from the various guidelines about atrial fibrillation. So what this is about is making this process a bit more transparent and removing this gray box and provide information there. One of the criticisms that we frequently hear from various groups is that their field is special. And because their field is special, they can't apply something that is a generic framework. Now, my answer to that is that every single field is special, and the surgical interventions have a limited body of evidence, the public health interventions have this evidence, and so on. Because you're all different, you all are the same. And that is probably true because it is about a framework that can be applied across different interventions, and we believe that it can actually be applied, and I will tell you how it can be done, hopefully. So, talked about the determinants of quality. Let me start with the first criterion, which is design and execution or risk of bias. So there are general principles for observational studies and for randomized trials. If you look at observational studies, the four key principles really are a failure to develop and apply appropriate eligibility criteria, which can lead to under or overmatching in case control studies, or inappropriate selection of exposed and unexposed groups in cohort studies, flawed measurement of exposure and outcome. Once again, this leads to difference in measurement of exposure, and therefore it can lead to bias. Failure to adequately control for confounding, and incomplete or inadequately short follow-up are four key criteria. And it becomes pretty clear that the assessment tools that we have for observational studies at the present time, there's the new Newcastle-Ottawa scale, for instance, they are not, they won't fit every purpose. So that your body of evidence, it is possible that for your observational studies, you need to look at specific criteria that probably fall into these broad issues here, but that sometimes you need to develop the data abstraction tables specifically for your question. In randomized controlled trials, we have issues such as lack of concealment, intention to treat principle violated when it shouldn't be, inadequate blinding of the different groups that could be blinded, outcome assessors, care providers, statisticians, and so on, and patients obviously, loss to follow-up, early stopping for benefit, although that may possibly fit better into an overall assessment of, well, anyway, so early stopping for benefit of trials is likely overestimates results, and then selective outcome reporting. Now, these are general principles in terms of design and execution of trials. I will give you an example now, not from the vaccine field. I don't want you to get involved with the topic. I want you to get involved with the methods, okay? So, this is an example looking at serious adverse events from a medication given for chronic asthma patients. And what the systematic review authors did is they identified approximately 30 randomized controlled trials that fulfilled inclusion criteria, and they specifically looked at the reporting of severe adverse events. They found 30 trials that are depicted here. I will make this larger. They used the Cochrane risk of bias tool and looked at three key criteria for assessing bias as the first criterion, limitations in design and execution, looked at bias in these trials. And a green dot basically means that was appropriately performed. It's a judgment by the authors of the systematic review in terms of what is reported. A question mark means that it was hard to tell, it was not reported, and even contacting the authors didn't provide the information, and red means that it was not done. So in other words, for this particular first example here, this study was a study that should have reported on serious adverse events, but it did not. So in other words, there's a risk of selective outcome reporting. It's something that was discussed widely the past couple of years. Some nice papers also there in JAMA in terms of selective outcome reporting. Anyway, over the body of evidence of 30 studies, 30 randomized trials, this is how it approximately looks. So another way to depict this is that approximately 50% of the studies possibly are at high risk of bias in terms of the overall estimate of effect for serious adverse events. So let's say that the meta-analysis showed a relative risk of 2 for serious adverse events. You don't really know how large it is because 50% of the studies didn't even tell you about them when they should have had the data. Okay, this is an imperfect representation because it doesn't weigh the studies, but it gives you a number count of the studies that didn't show that. Okay, there are two things that become clear. One is that it's pretty complicated, right, to make these judgments. But it would be more complicated for a general practitioner to make this judgment than it is for somebody who's trained in the methods and who has spent time reviewing the literature. The other thing that becomes clear is that you do need to make an overall judgment because all of these studies fulfilled your inclusion and exclusion criteria. Now, you could go out and say, I do a sensitivity analysis and look at whether there is a difference in the estimates of effect. But under those circumstances, you don't have the estimate of effect. All that you know is there is another 15 studies. We don't know whether the risk is even larger or smaller. You need to make an overall judgment. And the judgment would be one whether you think that there's a risk of bias that would influence your confidence in the estimate of effect. And I've provided you with this information about 30 studies, about 15 didn't report on these serious adverse effects. And the question now is, do you believe that this risk of bias, of selective outcome reporting, would be a concern in expressing your confidence in any estimate of effect that you have? And you all have to answer. You can ask for more information. Do you need more information? No? Okay, then I'm going to ask you. So who believes that in this example, simple example, the risk of bias in terms of expressing any risk estimate for serious adverse events would be a problem? You have to all make a judgment, and I will ask you at the end why you didn't make a judgment. So raise your hand if you think it's a problem. Okay, who thinks it's not a problem? And you think it's not a problem? Okay, why it's not a problem? Why is it not a problem? Okay, then let me go to don't know undecided. So who is undecided? So tell me. Okay. As far as I can tell, there was then nobody who said there was not a problem, or was there anybody who said there was not a problem? Tell me why you are undecided. Okay. What is the information that you would need? Okay, got you. Anybody else who was undecided? Why were you undecided? Was it mostly because of information that was missing? Or somebody who would say, it's not a problem? Okay. More information, I buy this argument. It's a quick exercise. I can't provide you with much more information in the time frame. But the point is, so there was, as I remembered it correctly, there was nobody who said this is not a concern. Actually, a majority of you, about 80%, probably raised their arm and said it's a problem, right? There is a risk of bias, possibly a risk of bias. And in the real world, one or two reviewers would make this judgment and would possibly downgrade the quality of evidence because this is really a problem, right? It is really a problem. Because any estimate of effect would be totally uncertain. Even if you get an increased risk of 2, it may be actually 5 if everybody had reported it. Okay. All right. I'll give you another quick example. So you may have a table that, excuse me. So you may have a table that looks like this, smaller body of evidence. This is a question that deals with giving anticoagulation to patients with cancer. A systematic review that we did is a series of one of a series of systematic reviews, and the table may look like this, where now you say we can prevent mortality by giving patients with cancer anticoagulation because they are at a high risk of having a thromboembolic event. I get 5 studies, and when we actually do the assessment, the 5 studies, they were all blinded. There was really concern, major concern, only in about 1 study that where there was some loss to follow-up that was greater than we hoped it to be. So it's a judgment at the end that you need to make. This is what you've got. You assess the key criteria, in this case for randomized trials, and you need to say, do we downgrade or do we not downgrade? Obviously, this would come, as you said, you need more information, and you would go through a detailed assessment. But if I were to present a table like this, is there anybody who would want more information? If I were to ask you, do you think risk of bias is a problem or not? Yes? Okay, so the duration of the study. Let's say that they all had adequate follow-up, so they were all 2 years. Yes?
What were the issues with adequate sequence generation?
Okay, so what were the issues with adequate sequence generation? They were all described as randomized controlled trials, but we couldn't find in the paper exactly the method how they did it. And that was labeled as unclear. So we were very severe in our ratings. At the same time, so it's good that you raised this issue, when people describe allocation concealment, it would be very unusual that they wouldn't adequately randomize, because it's very hard to do to conceal randomization without proper randomization. It's almost impossible, right? So we were very severe in our rating. We said it was not clearly described, but in reality, you could use this collateral information to say it's probably not a problem in 2 of these studies. Yes? Okay. What do you want to know? Okay. The relative importance, another way to look at this is to say, did this study influence the estimate of effect, right? Was this study in any way showing larger effects or smaller effects based on the fact that they had incomplete outcome reporting? And I can tell you that particular study, so if you go back, this was the study by Clerk. This study actually was very much within the overall estimate of effect. So it was not either showing a larger effect or a smaller effect. So that question was raised earlier. This assessment frequently requires you looking at a forest plot, right? This is a forest plot of showing the individual estimates of effect with the confidence interval. We did a subgroup analysis here, but the red dots represent the 5 studies. So you need to look, right? And now you know that this particular study didn't influence the overall estimate of effect, but it fulfilled your inclusion-exclusion criteria. So going back to this table, I will now ask you, based on these 5 randomized controlled trials, this is all that you have. We can't this time ask for more information. You need to make a judgment. In the ideal world, you would have more information, obviously. I would ask you, so who thinks under those circumstances the risk of bias is a big concern? Who thinks it's not a concern? Okay. And there's still some people perhaps undecided, a couple people undecided at the most. Everybody thought it was not a concern. These were 2 relatively clear-cut examples. There will be lots of judgment in between, a lot of judgment in between. The key is to describe it transparently what actually happened. So in the second example, we would say, despite the fact that one of the 5 trials had possibly incomplete follow-up. We didn't downgrade the quality of evidence because it didn't influence the overall estimate of effect, or because all of these other quality criteria were correct. So overall, we would not downgrade. So it's about transparency, so that next time when you update your review or your guideline and you have another 4 studies, you actually remember why you made a certain quality assessment, or because somebody asked you why you made certain quality assessment. You just are transparent. Okay, I will take you through these individual criteria. Now, the second criterion is inconsistency of results. And what we are looking for is relates to inconsistency between different study results. In other words, we are always looking at the totality of evidence. Are the studies showing different effects? And if they do, we look for an explanation. And we usually use the PICO format. That's why the PICO format is extremely helpful. It will come back with indirectness as well. We look at whether there are differences in the population, the intervention, the comparator, or the way that the outcome was assessed, despite it maybe being all certain, being myocardial infarction or allergic reactions, was the different ways how this was measured. Does that explain the inconsistency? If it doesn't, then we would usually downgrade if we can't explain the inconsistency. So we lower the quality. This is an example, and it makes 2 points. One is, once again, we look at the totality of the evidence. This is 5 studies that actually looked at using reminders as opposed to controls for and then measuring so they used letter reminders in patient groups, and then measured the outcome of whether recipients of the reminders were immunized. And the 5 studies, across the 5 studies, 1, 2, 3, 4, 5, the overall estimate of effect was an increase of about 60% in the uptake of immunization, with fairly tight confidence intervals here, relatively tight confidence intervals, and these 5 results. So I'm going to ask you, are there concerns about inconsistency in the results between these studies? Do you think that these studies all pretty much show the same? Most of you are nodding. Okay. It's pretty clear-cut. So what are your criteria to look at this? There is no one criterion, and there is no yes or no answer necessarily, but there are indicators of that make you confident. Perhaps you were nodding. Perhaps you can why do you think that they are consistent? Anybody? If you use the microphone, yeah.
The estimate of effect is all in the same direction. So.
Okay, so they're all in the same direction. Okay, all showing benefit.
There are, the overall estimate is, has confidence intervals that don't overlap. 1.
Okay, so they are significant, statistically significant. Yeah. What else? Anybody else? Okay, I can tell you how I would have looked at this. I would have said, okay, the estimates of effect are all still relatively similar. It always depends on the scale, but they all are relatively similar. I would have possibly not looked at whether they all show benefit, because the inconsistency can still be of concern if you're looking for a certain effect, and I'll get back to that. But I would have possibly said they're all relatively similar. The confidence intervals are all overlapping, and the confidence intervals of the individual studies. And then we have 2 statistical measures that tell us about it, tell us about inconsistency. They are also not perfect. One is obviously the p-value, testing for heterogeneity. The p-value here was relatively high, basically refusing the hypothesis that there is heterogeneity, or confirming that, not rejecting the hypothesis of homogeneity. And the I-square value here. I-square is a measure of inconsistency and it expresses the proportion of inconsistency that is due to variation between study results as opposed to random variation within the study. So that a value of 100% indicates that there's lots of difference between the studies, between the estimates of effect in the studies. 0% indicates there is no concern. There are some interpretation guides. But anyway, so there are 4 factors that we typically look at, and under those circumstances, most of you or nobody had concern about this being fairly consistent results. What about this? Similar type of intervention, similar outcome. Are they homogeneous or is there inconsistency? Okay. Why are they inconsistent? They are on one side of the point estimate. Why are you concerned about the inconsistency? Yeah, pretty far apart. Okay, only 2 of them. They're far apart, right? And the confidence intervals are not overlapping, as we just talked about. We talked about I-squared, it's 97%. We talked about the p-value, it's highly significant. So we have these 4 indicators, right? I showed you 2 extreme examples. There will be lots of examples in between, okay? Where you need to make provide a much better description. But the point here is, it's an important point actually, that they are probably heterogeneous, despite the fact that they're on one side, because you mentioned the effect is quite different. So if you were looking, because the intervention comes with certain cost, under those circumstances perhaps no harm, but cost, if you were looking for an effect of at least a 3.5 increase, you would be uncertain whether it really is a 3.5 increase, because one study showed the relative estimate of effect of 1.92 and the other one of 6.77. So the heterogeneity in terms of whether you could apply these results in a recommendation without lowering your confidence would probably influence it. Okay. The heterogeneity would influence it. So we look at these 4 issues here that I just described. I-squared, p-value, overlap in confidence intervals, difference in point estimates. The third criterion is directness of the evidence. I'll move through this relatively quickly, although it's a very important issue for you. We once again look at PICO. Is the evidence that we actually find direct enough to answer the question? Directness covers the issue of generalizability, transferability, applicability. We strongly believe that each of these concepts doesn't really cover everything, and that it's much better to think of it in the PICO framework. That is, once again, are there differences between the evidence and how you would like to see it applied? And so we look at, is the population the same? Or is it similar enough that you don't lower your confidence that the estimates actually apply? So when you transfer results from adults to children, can we be confident that the results apply to both population groups? Interventions. You are trying to make a recommendation for a class of vaccines, and all of the evidence is coming from the older vaccines, and there are a couple of newer ones in the group. You need to make a judgment. Ideally, you have evidence to support it, but sometimes you don't, and you need to, once again, generalize it or apply it to a slightly different question. The comparator, is the comparator appropriate? So you may be interested in making a comparison against the old vaccines, but all you have is information about no vaccine being administered or placebos being administered, which would lower your confidence. And then finally, outcomes. Is it an important, patient-important outcome or a surrogate? How confident can you be that the surrogate outcome really is related to the important outcome? So hepatitis B infection and liver cancer may be one example where you need to make this judgment. Or, but just by inducing an immune response, you may not prevent mortality, and you would lower your confidence possibly. So these judgments are critical. And it comes back to the question formulation, the issue that you mentioned earlier. Sometimes we start with the patient-important outcomes. We would like to see information on liver cancer. This is what we are looking for, but we don't find this information, so what we represent is hepatitis B infection, perhaps. And then you need to make a judgment of whether you can apply the relative estimates of effect to your recommendation. Can you take these relative estimates of effect, or is your confidence in these relative estimates of effect, because it may be just driven by the baseline risk for mortality, are you confident that they are that they actually really apply narrowly? Can you take them and need to make a judgment that they are indirect or direct? Okay, so you use the indirect outcome, you use the relative effect measure possibly from hepatitis B to make inferences about what happens to liver cancer in terms of different baseline risks. When you do that, you usually, or in many instances, you would lower your confidence in estimates of effect. Okay, and then that's why it's not necessarily covered well by the term generalizability, transferability. Indirect comparisons are critical here in making judgments about directness. That is, if you're interested in intervention A versus intervention B, and you only have information from intervention A versus C and B versus C, then you may downgrade the quality of the evidence or the confidence in the estimates of effect because of this indirect comparison. And that is frequently the case for newer interventions, obviously, because usually the industry is not interested in making head-to-head comparisons. So, for instance, you may have one rotavirus vaccine being compared to no intervention and another one being compared to no intervention. But what you would want to know is how well they compare against each other, just hypothetically as an example. So under those circumstances, if you don't have the direct information, the direct studies, you need to make a judgment how confident you can be in the indirect comparison, that is, the estimate of effect that you get here versus the estimate of effect that you would be getting there. Okay. Publication bias. So who feels he or she would hear a little bit more about publication bias? Okay, there are several people in the room, so let's do that. So publication bias, in our view, should always be suspected, right? Unfortunately, that's probably reality, that a lot of the studies, in particular observational studies, remain unpublished. Investigators have investigated a hypothesis, it doesn't confirm the hypothesis, it ends in the file drawer. So that's why it's also called the file drawer problem. You don't write it up because you have a better study that you would like to publish, and then you never get back to what you've done previously. So observational studies are particularly prone to publication bias. You should suspect it when you have only a few small positive studies, when there's lots of for-profit interest. That's what the empiric evidence shows. There are lots of methods to evaluate it. None of them is perfect, but it remains a problem. So one of the ways to conceptualize publication bias, for those of you who wanted to hear a little bit more, is the following. So in the 1980s, there was a group of investigators that questioned whether intravenous magnesium reduces the risk of dying in patients who had an acute myocardial infarction. And they looked at all of the studies that were actually reported, all of the randomized controlled trials under those circumstances that were reported. And they found a relatively large evidence base. They found studies that in part included several thousand patients, where here you see the number of patients on a logarithmic scale, and here you see the odds ratio for the risk or the odds of mortality if you have received the intervention. And this is what the investigators found. They then went to calculate an overall estimate of effect, the meta-analysis that Salim Yusuf did, and they found that there was an approximate 20% odds reduction in the risk of dying from intravenous magnesium. A group of investigators, in part the same investigators who were involved in the meta-analysis, then went on to do a mega trial, 50,000 patients. And that's what the mega trial showed. The mega trial showed that the odds ratio was 1.0, right? So a very large trial that didn't confirm this meta-analysis. So why was that the case, right? And the answer is in the picture, is in this particular picture. As you can, if you look at this carefully, any overall estimate of effect should be influenced by random estimates of effect of the various studies, right? And each of these dots represents an estimate of effect from a single study by its size. So just because of biostatistics and randomness, you should see, in most circumstances, a random distribution of small studies around the point estimate of effect on both sides of this particular overall estimate of effect, just because of randomness. The smaller the study, the more likely they are to deviate, and you would have a random distribution of small studies that show much larger or much smaller effects. In this case, it's not the case. All of the studies are positive except for one, right? And even the small studies are only on one side. So it's an example of publication bias, and it explains under those circumstances why the ISIS-4 study actually didn't show it, because there are probably 10, 15 studies that were performed that showed actually an increase in the risk, but were not published because it didn't confirm the hypothesis. Okay, so funnel plots are a good way to conceptualize publication bias. They can be used. The guidance is that you should have at least a certain number of studies, between 5 and 10, in order to use this, but sometimes it gives you information even with fewer studies. A symmetrical funnel plot, which basically plots the size of the study here expressed as a standard error, which is a better expression, a better way of measuring it, against the estimate of effect. So ideally, you would have a symmetric distribution around this. Under certain circumstances, you don't have this, and then you should be particularly more concerned about publication bias. So there are no clear-cut methods for doing this, but there are indicators such as using plots to assess publication bias. Because if you don't do this, estimates of effect that would be perhaps 0.6 based on publication, truly based on publication bias, may be much larger, or you may see an effect when there was no effect. Okay? All right. Imprecision is the fifth criterion. Imprecision has to do with small sample sizes as well as small numbers of events. This both then leads to possibly wide confidence intervals, and it will provide or will cause uncertainty about a magnitude of a true effect. I'll give you a couple of examples. When we do this, we look at the totality of evidence. This is a similar type of example that I showed you before from the immunization literature. Under those circumstances, the investigators try to address whether inactivated vaccines are related to otitis media vaccines to prevent influenza, and the outcome was otitis media, as I just said, and they found one randomized controlled trial that addressed that particular question in that particular patient group, and this is the results. So about 120 people involved, 24 events. This is the estimate of effect, 0.48, confidence intervals like that. So who would think there is a problem with imprecision? Yeah, why is there a problem with imprecision? Wide confidence intervals, right? So it's wide confidence intervals. We are not necessarily worried about a single study, because a single study can be very large, very tight confidence intervals. But that's basically the point. So you wouldn't know whether it's really associated with it. As I said, only 24 events, small number of patients overall. Alternative example, many of you have seen these examples, but I think they basically make the point. Once again, similar type of question. The question is not that relevant here, but under those circumstances, there are now 5 studies, about 1,700 patients enrolled in these studies. This is the estimate of effect. Who would be concerned about imprecision? Nobody? Okay, so point to make here is, yes, estimates of effect are precise. There are approximately 250 events in 1,700 patients. That's really it's a large number of events and a fairly large number of patients. We are not concerned that a single study is not statistically significant. We don't look at single studies. We look at the overall estimates of effect when we assess imprecision, but we consider all the studies, even if they contribute very few events, ideally also if they contribute no event. So this is the reason. There are lots of events and lots of people. So we provide some guidance for assessing imprecision, and I will take you through this relatively quickly because that is one of the issues that most frequently comes up. And in fact, there's a reliability study that the evidence-based practice centers just did, and I think this is out for consultation, so not confidential information, but one of the major criteria for not coming up with the same ratings for quality or confidence in estimates of effect was that there was disagreement about judging imprecision. And the main reason is that the people who are doing these type of assessments didn't have any guidance. Any guidance will be likely imperfect, but it will still lead to greater consistency and providing help for those who need to make judgments about imprecision. So we've developed some criteria that the first one reads that if the 95% confidence intervals in systematic reviews excludes a relative risk of 1 and the total number of events or patients exceeds what is called the optimal information size criterion, precision is adequate. So in other words, if you go back to that example, statistically significant, and for a systematic review, you may want to say that this is precise if the optimal information size criterion is fulfilled. The optimal information size criterion is nothing else but a reasonable sample size calculation for this particular intervention. So, to come back to that, what we frequently find is overestimates of effect, right? And we also frequently find spuriously statistically significant findings. They happen 5% out of the time, right? So one way of addressing of whether beyond statistical significance we can be confident that we really have a sufficient body of evidence is look at optimal information size, and it would be a sample size calculation just as for any trial or observational study, power calculation, where you calculate that given for a certain estimate of effect, do you have a sufficient number of events and a sufficient number of people enrolled in the study to actually show a certain difference. And if that's the case, in addition to seeing the statistically significant findings, you can rest assured that imprecision is unlikely to be a problem. And sample size calculations are simple. They are based on the p-value, obviously, on the power, and on the difference that you actually expect. And that pretty much is all that you need. And that, once again, can be done very, very simply. It's one guide. And then if the 95% confidence interval includes appreciable benefit or harm, and the suggestions are to use relative risks of 0.75 or 1.25 as a rough guide, rating down for imprecision may be appropriate even if the optimal information size criterion is met. In other words, if you find a relative risk estimate of 1, but the confidence intervals are very, very wide, you obviously can't exclude that there is still appreciable benefit or harm, and that should worry you and shouldn't make you too confident that there really is no association. And the guides are what they are. They really depend on the thresholds that you would like to provide. The optimal information size, once again, just to provide more guidance here that you can find in the handbook there as well in the grade profiler, we suggest the following rule. If the total number of patients included in a systematic review is less than the number of patients generated by a conventional sample size calculation for a single adequately powered trial, consider rating down for imprecision. And as I said, this has been called optimal information size. This can be made clearer. So if you were to consider this a relative risk reduction of 25%, this would be a relative risk reduction of 0%, so no effect. If you find a result that looks like this in your meta-analysis, so a point estimate that is larger than a 25% risk reduction, confidence intervals not overlapping, it's pretty clear-cut, the results are not imprecise. If you find something like that, and your threshold for a relative risk reduction is really 25%, and this is what you would need to achieve in order to be confident that the results are precise enough, despite the fact that they may be statistically significant, you may rate down for imprecision because you really are not confident that the effect that you would try to achieve is achieved. At the same time, this is the example that I described, you may see no effect of an intervention, and the confidence interval may be relatively narrow and not include what we use as a rough guide, the 25% relative risk reduction. You may say this is precise enough, we shouldn't downgrade further, we don't expect additional information to change this dramatically, as opposed to a situation like this, where despite the fact that you have no effect, your confidence interval still includes the possibility of an appreciable benefit or harm. Under those circumstances, you really are not very confident that you can really say that there is no effect. And the issue then when you go to guidelines becomes that your thresholds are becoming key, and the thresholds usually are based on absolute estimates of effect. So just to take you through this relatively quickly, so if, for instance, you would see mortality estimates as follows. So these are absolute estimates of effect, the risk difference of 2%, 0.50%, and a 0.5% increase. So let's assume that your threshold for applying an intervention would be a risk difference of 0.5%, so 0.5% or 1 out of 200 people who receive the intervention die less. And if your true estimate of effect was the following, right, so this is including thresholds, was the following, you would say, okay, I have enough information, I'm pretty confident that these estimates of effect are good enough for me to say that we don't need to downgrade. If your threshold, however, because of cost downsides and other side effects, would be a risk reduction of approximately 1.25%, 1%, sorry, and it would be, which comes with an NNT of 100. Sorry, yes, 100. Excuse me. So a risk difference of 1%. And if your true estimate of effect was the following, despite it being showing benefit, it would cross this line. You may still seek more information, or you would ask for more information, and you might downgrade for the quality of evidence. Okay? So thresholds really become important when you look at guidelines. Okay, there are rough guides that you can use when you make this judgment. These are curves that we produced, which basically tell you about the optimal information size, and you can see where your body of evidence actually falls on these curves. What it explains is if you are above the line, the optimal information size criteria are met for the various relative estimates of effect, the control group event rate, and the total sample size. So this is fairly easy to apply if you use this as a guide as a rough guide. Okay, so that will hopefully help with making judgments about precision and imprecision. The last 15 minutes or 20 minutes that we have before the break, I will focus on what can raise the quality. There are 3 criteria. The first is when you have very large estimates of effect. And we use two guides. One is a relative risk reduction of 50% or a relative risk of 2, or we are even more confident that an effect truly exists if the relative risk reduction is 80% and relative risk is 5. You could just think of this as the parachute example. Sometimes the observational study evidence comes with such large effects that we increase our confidence that the effect truly exists. And I will not spend much more time on that. These are the guides that we have out there. They are related to precision, so ideally these estimates are also precise. Okay, and then I give you just one example to clarify one frequent misunderstanding, and that is, now, what if you have an estimate of effect that is statistically significant and exceeds the effect that I just mentioned, the relative risk of 2, but the individual studies are not necessarily showing all an increase of a relative risk increase of at least 2 or relative risk of 2. This is just to emphasize the point. We do look at whether the results are precise enough when we make a judgment about the magnitude of effect, but we base it on the overall estimate of effect. So if the overall estimate of effect is larger than 2 with sufficiently narrow confidence intervals, ideally those that meet the optimal information size, we would upgrade the quality of evidence. And that's one example. The next example for raising the quality is some hypothetical example here in this case that we have discussed with the SAGE group in particular, because that was a question that they had, whether those effect relations also apply to populations. And because those effect relations or those response relations are one criterion for upgrading the quality of evidence. So if we look at this hypothetical example of vaccine efficacy, if you would find the following on a population level, if 50% of the population was immunized and you find a 20% lowering of the risk, as opposed to when the proportion of the population that is immunized becomes larger and there would be an even further increase in the risk, this would qualify as a dose-response relation, because it clearly expresses that, that there's efficacy of a vaccine, right? The more people who are immunized, the lower is the risk on a population level. So that would be one example for dose-response relation as opposed to the other clear-cut dose-response relations in the clinical arena. And then the third criterion that is a bit more complicated relates to plausible residual confounding and biases, and they may be working to reduce a demonstrated effect or increase an effect. And I will present you with an example from the clinical literature and then tell you that it applies to the vaccine literature as well, in our view. So those of you who have treated patients with diabetes or had relatives with diabetes may know that based on early work on the drug fenformin, this drug may cause lactic acidosis, which is a very severe condition with a 50% mortality. That a drug that is based on this fenformin, which is called metformin, was suspected to have the same toxicity. In fact, it's on the labeling of the drug, and it's very commonly known amongst practitioners because there was a lot of concerns by the producers that the drug would actually cause it. So, given that that is the case, it is very likely that there would have been over-reporting of this particular complication, because all the practitioners who treat patients, all the GPs, or many of them, would be aware of this particular problem. Now, when people actually looked at the evidence and looked at the large observational studies that were done, despite the fact that there was likely over-reporting, the observational studies failed to demonstrate an association, so that all biases, or in this case, outcome reporting, which can be considered a bias, would have actually led to showing an association, despite the fact that no association was observed. Under those circumstances, groups may increase the quality of evidence. And a good example is really from the vaccine field, in my view at least, and it has to do with the MMR vaccine and the concern about autism, where there was a lot of concern based on the spurious publication or the publication in the Lancet. And this is based on a Cochrane review. When the Cochrane reviewers actually looked at the evidence, at the observational studies that were out there, they did not find an increased risk of autism, right? They did not find it. So despite the fact that based on the publication in the Lancet that was withdrawn, and the sensitivity and the possible over-reporting of vaccine adverse effects, in this case autism, despite that, there is no association, and that may increase your confidence in the fact that there is no association. Exemplified by the fact that the Lancet had to actually withdraw the publication with the falsified data, the fabricated data, which actually supports it, right? Okay, so those are criteria for upgrading the quality of evidence. So there are 3 criteria for upgrading the quality of evidence, so that overall we would be looking at the following. We would be looking at, and I apologize, I can't move from here. I was told that, except for taking the microphone, so I need to stay here and turn around a little bit in order to point to the screen. But that we would start with a body of evidence from either randomized trials or observational studies. We don't suggest mixing them. We suggest, if you have a body of evidence from randomized trials and a body of evidence from observational studies for one outcome, to do this separately and see which body of evidence ends up as higher quality and report that, or report both. That you would start with an initial quality rating of high or low, and you would assess whether these 5 criteria lower the quality of evidence, and whether these 3 criteria increase the quality of evidence, and then come up with an overall rating that is in 4 categories, clearly recognizing that this is a continuum. There is a continuum of the quality of evidence. We use categories in order to facilitate communication and to provide a rough, to provide an estimate or information to practitioners how confident they actually can be in this particular recommendation. That is the overall summary. This is done by outcome. The overall quality of the evidence reflects the extent then of our confidence that the estimates of an effect, as I said, are adequate to support a particular decision or recommendation. Guideline developers must specify and determine the importance of all relevant outcomes in our view, and the overall quality, as I also said earlier, of evidence is based on the lowest quality of all critical outcomes. So now this is something to pay attention to. It has to do with assessing the overall quality of the evidence. Now, let's assume, this frequently comes up, and it has to do with concerns that we over-penalize, or that we are too severe, too stringent in the application of these criteria. So let's assume that we have a systematic review and meta-analysis of several critical and important outcomes, okay? The intervention be what it may just be any intervention. And hospitalizations were considered to be a critical outcome. And this is what you would find. You would find a risk reduction for hospitalizations. No downgrading takes place. It's high-quality evidence for hospitalizations. Let's assume that you have a second outcome, which is mortality. It is considered critical, and the quality here is moderate, and perhaps this is due to imprecision because you're not entirely sure whether mortality is increased or decreased, or whether there are other effects on mortality. And let's now also assume that you have a third outcome that is rated as important but not critical, which is nausea, and it comes with the following estimate of effect. And a fourth outcome that is serious adverse events. It's critical, and it's considered high because the confidence interval is considered to be narrow enough under those circumstances. So based on what I said before, what would be the overall quality of the evidence? It's a test question, the first test question. There's going to be lots of test questions. No, I'm just kidding. But so what do you think the overall quality of the evidence should be? Let's say that these were the 4 outcomes, and this is what you find. Moderate. So why is it moderate? It's the lowest critical, right? It's pretty straightforward. It's the lowest critical, so yes. The overall quality of evidence is not low because nausea, despite the fact that it is only low quality, it was rated as important and not critical. So moderate. Okay. Let's assume the following case. Now, mortality is a critical. So these are all critical outcomes now. All critical outcomes. Mortality is high quality evidence that this intervention reduces mortality. You were interested in disease-specific quality of life. It was rated as a critical outcome, moderate due to imprecision. Hospitalization was also high quality, and serious adverse events was also high quality. It was felt that there was narrow enough confidence intervals to not downgrade. So what would the overall quality be here? They're all critical. Okay, why would it be high? Okay, so if we were to apply the criteria that I just said, that it would be based on the lowest quality of the critical outcomes, it would be only moderate, right? But either you did the reading, or our common sense was similar to your common sense, that it would be wrong to penalize this body of evidence. And why would you say that? So you said 3 out of the 4 were high. That could be one way of dealing with it. Our way, or the way that we apply this criterion, because it is really important for many of your questions, I believe, is the following: this outcome that would determine the lowest quality of evidence is actually going in the same direction, right? And even having more information about it would not alter the recommendation that you would likely make, because there are 2 critical outcomes that clearly go in one direction. They cross the threshold for recommending an intervention against the serious adverse events, and it is very unlikely, apart from the fact that what I just mentioned, that you would ever get more information on disease-specific quality of life. But the point is, it goes in the same direction with the other critical outcomes, and under those circumstances, we would not penalize the body of evidence and maintain a high-quality rating. And that, in particular, once again, if the threshold for the acceptable harm is crossed. So where this is the threshold for where the serious adverse events should be falling into, considering the benefits that are obtained. Okay? So it's important. So the quality of the evidence would be high rather than moderate. Okay. Last example, all critical outcomes. Hospitalization is one outcome. Disease-specific quality of life is another outcome, high and high. Mortality is moderate. And the serious adverse events are high. And if you take all of this together, if you take these effects together and then look at how large an increase in the risk, plausible increase in the risk of serious adverse events you would be willing to accept in order to recommend this, if you consider that, and if you consider that it wouldn't cross the threshold, that it would not be clearly on one side of the threshold, it means that you really do need additional information, and that your overall confidence really should be reduced, and under those circumstances, rightly so, the overall quality of the evidence would be moderate, based on the critical outcomes that you have here, the lowest critical outcome, in particular because the threshold is not crossed. Okay, so the overall quality is determined by the lowest critical outcome, except for the circumstances, the situation that I described there. Okay, so then to sum up this presentation. Again, I'm glad that we are staying on time. The rest of the afternoon, in particular after lunch, will be much more your work. In fact, it will be your work for the most part. I will speak relatively little, except for in my small group, and you will apply what you learned in the morning. Obviously, no tests, but hands-on exercise. So, to sum up, we define the overall quality of the evidence, and this is very much in line with what the ACIP has decided to do. It basically determines the confidence in estimates of the effect of the intervention when we provide a rating of 1, 4 plus A or high. We are very confident that the true effect actually lies close to the estimate of effect that we have obtained, down to the very low category where we have very little confidence in the estimate of effect, and the true estimate is likely to be substantially different from the estimate of effect that we have in front of us. So what we have covered so far is the following. We've talked about question development. We've talked about to some degree about the evidence profiles. We've talked about the 8 criteria with examples, and we've talked about this issue of how we arrive at the overall quality of the evidence. And this is what we're going to apply in the first small group session. Okay. In the break, I'll be happy to help those who had difficulties with installing the software. Possibly I can solve some of the problems, hopefully. But what we will be doing after the break is I will just provide a very brief introduction. We will assign small groups or divide up into small groups. And the introduction will tell you what you would be doing for the rest of the afternoon. Then we'll get together once more in the large group where we'll talk about, once again, this process then, and you will do this in the small group then as well. And we finish up with issues, challenges, questions, and feedback. We have 2 minutes, 3 minutes for questions until it's 2 minutes to 12. Do you have any? Yes.
Slide with the different examples of how you would rate things with the strength of evidence back of here. Okay, yeah, in this situation, what about the situation where for the adverse events you had poor quality evidence, low evidence, but it didn't show any risk?
Okay. So there must be reasons for why you rate it as low quality. And given that there are reasons for low quality, and given that you must have determined that they are critical for decision making, we typically suggest that you lower your overall quality of the evidence, because once again you've determined that it's critical for decision making, and for some reason you don't have the information that you really need. Now, there are some exceptions, as I said earlier. Sometimes there are suggested or surmised some severe adverse events that really don't exist, and all that you can gather is observational study evidence, right? And you fail to detect an association, and under those circumstances, it is maybe appropriate to say that this is really not a critical outcome. It may be important because you want to report it, but it is not a critical outcome because there is no association. People make up all sorts of associations, but sometimes they don't exist. And in particular, this could be then supported by when the events are very, very rare in a certain situation for the severe adverse consequences. And under those circumstances, it's not that the evidence would change, but that your rating of whether it's critical or not would change, and therefore it would not be downgraded as for the overall quality of evidence. You see, because people make up but we always think of a lot of severe adverse events, and sometimes they just are not related to it. Well, it really, unfortunately, happens after the fact, but when you have the evidence, that's why you can't completely separate it. You make this judgment after you've put together the evidence profile. because you find out that despite the fact that the panel thought it was a critical outcome, it really is not a critical outcome because it's not associated, it doesn't happen. So a practical example, for certain depression drugs, there was a concern about increased suicide rates, and when people looked at actually hundreds of thousands of patients at registries, there were really there was no indication of an association of suicide risk with this particular antidepressant drug. There were, in 1 million patients, only 20 events, and there was no, once again, the relative risk was not increased. So that under those circumstances, it may not be a critical outcome related to that intervention. And then there is another way of dealing with this that I will explain better after the break. Okay? Once again, this is for you to work sequentially to the process. The software can be downloaded. It's free. We regularly update it. There's a really major update expected in about a year or so that will, year and a half maybe, that will transform this in a guideline authoring tool where you actually can then just produce an entire recommendation. There is already a recommendation module in here. But so let me just start. When you open it up, you would typically create a new profile, which is shown there. So you click on new profile. You just this is to remind you that there is this context-specific help file, which, as I just said to Jean, is about 300 printed pages. So no normal human being would ever read this. But that's why it's context specific. So when you actually have a question in the profile, while you're producing something and you move the cursor around, you get the question mark, and that's when you can click, and it brings you to the relevant sections in the handbook. Or you have a search function and things like that, which is really very helpful for most groups. So you start by defining the profile group, and what we mean by profile group is simply, so frequently you would work on recommendations in relation to hepatitis B vaccine, and there would be different recommendations. So you could just call this hepatitis B vaccine recommendations, or you could, under those circumstances, we are looking at rotavirus, you could just say rotavirus profiles or something like that. It's just then, because there are many groups who work on very different questions, and they want this to be separated, obviously. So profile groups. And then when you've opened this, you just say add a profile, and that will then open the interface with the question formulation. Just as a reminder, this is what you have to choose. There are 4 different types of questions that you can choose from. This is not to be filled out unless you click the edit button. This comes up automatically once you select the question. And this is how the question might be formulated. Is there a comparison, and are you dealing with a health problem or a healthy population? There's a pull-down menu there. Intervention, the comparator, and the health problem or the population, depending on what format you are choosing. And then the setting is something that you can fill out or not fill out. It relates to whether you're dealing, for instance, with an inpatient setting or an outpatient setting, or you can just click on this particular word, and the help file will explain what we mean by that. And then the next step is to then you start adding your outcomes, and your outcomes are, I will go through that in the handout in a second. The outcomes are obviously determined by the guideline panel, by the group that you're working with, and you start by adding the first outcome. Input the outcome name, and then it really takes you through it sequentially. You need to decide whether it's a continuous or dichotomous outcome, whether it is pooled in a meta-analysis or there are different pull-down options there. Then you start by entering the number of studies that were identified. Once you've done that, it asks you for the underlying study design, and then you do your quality assessment one after another. And the big benefit here is, as I've repeatedly said, you don't forget things, you work through it sequentially, and you make sure that you provide information that is relevant for your judgments, indicated here by the red arrow. These little pin buttons there mean that you should provide an explanation or a footnote. We've called it footnote here. There's a footnote manager, so you provide a narrative description of why you are making certain judgments that serves as a record. It actually is automatically integrated in the evidence profiles then. And then you get to the screen that asks you to provide the numerical information. So we have different ways of filling this out. One is we can directly import from a Cochrane review if you have the HTML files or the relevant files. Alternatively, the information is put in. You put in the number of events and the number of the total number of patients, the relative estimates of effect. One question that frequently comes up is how you choose these control group risks. I'm just saying it now. It will become clear as you're as you're working through it. The control group risks basically reflect reasonable estimates of what we just talked about, burden of disease or baseline risks in a population. And it helps you because the relative estimates of effect are usually similar or the same. It helps you to determine what happens in terms of absolute estimates of effect. So for instance, while for this particular outcome the relative risk may be 0.92, so a very small 8% relative risk reduction, it does influence how large the absolute effect is on the basis of what you think your burden of disease or your baseline risk truly is. So, and that, once again, the absolute estimates effect can differ quite dramatically. So obviously with about a third lower baseline risk, you would have a third lower absolute benefit or a third lower risk difference. So it's important to sometimes we talked about it over lunch, to just get a sense of what the different burden of disease or baseline risk does to your absolute estimates of effect. Then quickly to continue, there's a possibility of including continuous outcome measures. That is not part of the example here, but it's all there. And then just here, it should be. Then you can actually preview what you're doing in the preview tab, preview the summary findings table. You can see how it looks as you progress through the exercise, and there is also the print and export function in this particular screen. Two different ways of presenting it, the complete evidence profiles, or we have the summary of findings tables, which is the same information just condensed. You may want to take a look at that. And that, I think, is pretty much it. If you continue to use the software, you can check for softwares updates occasionally. As I said, we are doing this frequently. So any questions about the software? This was about 4 minutes, so we will do much more as we are moving through the small groups. So I'm going to speak about moving from evidence to recommendations. And as I said earlier, I showed this gray box in terms of the quality assessment, the quality of evidence assessment. When it actually comes to formulating recommendations on the basis of the evidence, we have probably been dealing with a black box because it's much more complicated. And laying out the processes that we went through is probably also more complicated because there's less written about it. But so let's talk about how we get actually to a recommendation and how we can perhaps make this black box more transparent. Starting with the definition that I provided to you, the strength of a recommendation reflects the extent to which we can, across the range of patients or population, or people for whom the recommendations are intended, be confident that desirable effects of a management strategy outweigh undesirable effects. And we make this category A or category B recommendations there. I mentioned the 4 factors to you. I will not go through them in great detail anymore because you have them in the handout. and we've talked about them a little bit, but I wanted to give you a little bit of a, well, I can skip that. It's not maybe that important to you, as I'm talking too much about history. So it is about weighing the benefits against the downsides here, or the desirable effects against the downsides. Now, it is pretty clear that each of these outcomes that potentially provide benefits against the downsides lead to this whole balance here being a continuum. The way that ACIP and other groups are doing it is that there are two categories, Category B and Category A, or strong and conditional, and for or against, as I've repeatedly said. But it is a continuum, so we just need to be aware of that. However, the continuum doesn't necessarily help practitioners in making decisions, because either either they are being told to do something if it comes to immunizations, I would have expressed it this way, to just do it, or they perhaps need to think whether the patient in front of them is the appropriate candidate. But there is not much more in between. It's either this or the other. So that at the end, it's really dichotomous decisions. And we provide a little bit more gradient to that decision by having what we would say perhaps four categories. So it's either do it or don't do it, stop vaccinating people with certain vaccines, or it's in the middle. And in the middle, a guideline panel may still say, we think that it's usually indicated, it's usually providing more benefit than downsides, or it's usually providing more downsides than benefits, and probably don't do it. So we weigh these factors by the magnitude of their occurrence, as well as the importance to the patients, as we've gone through the values and preference exercise. So, and if the panel believes that the benefits probably outweigh the downsides, they're not entirely certain, then they would make a Category B recommendation to provide the vaccine, or a conditional recommendation to provide the vaccine and immunize that population. If they believe that the benefits are not, that the downsides actually outweigh the benefits, they would do the opposite. They would say, it's probably not indicated in this population. However, it's certain values and preferences, risk takers who are extremely downside adverse may accept the vaccination and would want to receive it to avoid any potential disease consequences, and are not that worried about the adverse reaction that they experience, and they would accept it. Under those circumstances, the patient and the clinician just need to have a good conversation, and there needs to be informed decision making. Once again, I think there are situations in the immunization field where both of these conditions or both of these type of recommendations could be issued. Perhaps they are not, but I would have thought it does exist. Many instances it will be like this. You will make strong recommendations. They're either for an intervention because the benefits, as you look at the estimates of effect as well as how important they are, clearly outweigh the importance and the occurrence of the downsides, and then you make strong recommendations against. Right? That's the framework. You need to balance it out. It is complicated, and ideally you would use decision modeling. In most instances, you don't have that decision modeling where you actually plug all of this together. And that is the field that I mentioned earlier that really still requires a lot of work. But let's come back to some examples in terms of how this has been used. So I talked a lot about the avian influenza example and the oseltamivir example, and it is a good example for when what we just described is for what we just described in terms of the quality of evidence, where for an exception for where the quality of evidence may be very low, and you would still make strong recommendations, which in this framework is actually possible. So, avian influenza example that I talked about earlier. So we did use the methods that we actually have been talking about here with WHO in terms of developing guidelines for dealing with avian influenza. This was in 2006 we began the work. It's a panel that I chaired with 13 voting members. There were all sorts of representatives, clinicians who treated influenza A, H5N1 patients, infectious disease experts, basic scientists, public health officers, methodologists, and there was actually a UNICEF representative as a patient advocate. At the time, we had independent groups providing the systematic reviews. They looked at the RCTs. They looked actually at the RCTs that were obviously not performed in patients with avian influenza, but they were performed in patients with seasonal influenza, provided indirect evidence. This question came up a few times. There were case series of these avian influenza. At that time, there were 36 described cases out of approximately, so described in the literature, out of about 100 or so when we started this work. And then we looked at basic science evidence as well. That's what the panel came up with. So there was no clinical trial, direct clinical trial in this field, obviously. There were 4 systematic reviews that reported on 5 randomized trials in seasonal influenza. Hospitalization was one of the outcomes that, I'm just showing you the outcomes that showed some benefit here. I'm not showing you the full evidence profile. Odds ratio 0.22, not statistically significant, and pneumonia 0.15. So some benefit there, a relatively large odds reduction, but obviously wide confidence intervals in very few cases. 3 published case series summarizing 36 cases with a mortality risk of 1.0, but big problems in terms of when the drug was administered, a lot of heterogeneity in these cases. And then at that time there was no alternative that was more promising in terms of drug treatment, and the costs were $40 per treatment course. This is avian influenza, non-pandemic, obviously. So this is what the panel had in hand in their hands, and these were the first attempts. This is about, as I said, 5 years ago, the first attempts to make the decision-making more transparent with all the limitations that are out there, and with a much more detailed decision analytic modeling that you could have done. We didn't do it under those circumstances because it was rapid advice, but the panel laid out what their considerations were. So in terms of the quality of evidence, it was very low quality evidence because it was all indirect evidence, as I just described, the overall quality of evidence. In terms of the balance between benefits and downsides, yes, there was uncertainty, but the key issue here was that the mortality, the baseline risk of mortality was between 50 and 80%. Right, so dying, not only being infected, dying, 50 to 80%. That even a relatively small effect, as we saw there for pneumonia, it was a large effect, but even a small effect for preventing mortality or pneumonia, given that these were frequent, given the high baseline risk, would still lead to a relatively large risk reduction. So just consider that. You have an 80% baseline risk of dying. Even if oseltamivir had only a 5% relative risk reduction for mortality, right? It would still amount to a 4% absolute risk reduction, so 5 out of 80%, 4% absolute risk reduction, which is a number needed to treat of 25, with a treatment course of 5 days to prevent 1 death. And that is very different from many of the other interventions that we are dealing with. There was a lot of uncertainty around it, but that was one of the underlying considerations here, that despite small effects, large baseline risk, you may still have a large risk difference. Values and preferences. So it was considered that there was very little variability. Most patients would place a high value on preventing death, very low value on temporary nausea when most of these patients were very sick. On the neurologic complications, perhaps everybody thought it was very important to reduce hospitalizations, and the resources were considered to be not as important because it was $40 per treatment course under non-pandemic conditions. So relatively cheap. as I described here. There was another issue, and that was that the issue of regret came up. Many of these patients were pediatric patients, and that plays into the values and preferences, and most parents would have placed a high value in avoiding regret of not having done everything. So anyway, those were the considerations that influenced it, and this is the recommendation that was actually issued. In patients with confirmed or strongly suspected infection with avian influenza A H5N1 virus, clinicians should administer also oseltamivir treatment as soon as possible, and it was considered to be a strong recommendation based on very low quality evidence. A complete exception to the rule, right? For perhaps good reasons. Anyway, we use this as an example for when perhaps a strong recommendation is justified in the face of very low quality evidence. Explanation in terms of values and preferences. The recommendations places a high value on the prevention of death in an illness with a high case fatality. It places a relatively low value on adverse reactions, the development of resistance, and cost of treatment. And what we have in the background document is that the panel was asked to assume patients' values and preferences when making this decision. But what we actually provided in the full document was also the information that this recommendation was actually based on a vote, which we very rarely do. We usually have consensus methods to find consensus. So under those circumstances, the results of the vote were actually in the document. Does ACIP do that? Are the results of the voting there produced? Okay. It was new for WHO for sure. Okay. So one other point to touch on is implications of strong or weak recommendations. So for policymakers, a strong recommendation, I mentioned this earlier, policymakers means that a recommendation can be adapted as a policy in most situations, and for clinicians that most patients should receive the recommended course of action. For weak or conditional recommendations, I mentioned that also earlier, policymakers, there's a need for substantial debate and involvement of stakeholders. Clinicians, they should be more prepared to make shared decision with the patients. Now, from this simple decision table and from this simple decision table, we've moved with guideline groups to actually be more explicit. This is work that is, this is the area where we need a lot of work, a lot of work over the next years. But the decision criteria are the same. It's these 4 factors that I mentioned. When we now meet with panels, we have all of the evidence profiles prepared, as we are doing here, and we also have started to provide these additional summary tables, because frequently, if you're dealing with a lot of recommendations, there's not enough time to go through everything in detail and then provide the summary at the meeting, actually write the summary at the meeting, so that we have independent groups summarize it narratively. So for instance, this was a question about TB with the WHO guideline panel, where we then describe the evidence, provide an explanation for why there's low quality evidence. We then describe the benefits and the downsides and have a summary here. We describe the values and preferences, and we provide information about the potential resource implications that the panel assumed, and then we make these yes or no ratings, where once again it indicates that if you are very certain about each of these factors, that you are more likely to make a strong recommendation and less likely to make a weak recommendation. As you have a lot of no answers, you are more likely to make a weak or conditional recommendation, category B. And then we leave this open though. We just provide this, and we work with the panel through these decision criteria and find consensus, try to find consensus on each of these 4 factors, which, once again, ensures engagement. It ensures that everything is well prepared. It avoids the guessing at the meeting, and it provides the transparency that is being asked for what actually influenced these decisions, because it is these decisions that you need to make in order to move to a recommendation. And then the other possibility that you could that you can consider, or that we consider in the work with larger panels, is in order to move the work ahead, we have these neutral recommendations formulated. Is ACIP, are you doing that when you move to the panel? That you have the recommendations formulated, pre-formulated? Is that how you do? So in order to keep the panel engaged and make sure that they actually do contribute, you don't want to necessarily write everything out and determine beforehand what the recommendation is. So we formulate these neutral recommendations so that we have something to work with, and so that we're not going astray, and that all of the issues are covered in the recommendation, so that under those circumstances you could formulate it neutrally. The guideline groups recommends that fluoroquinolones are or are not used in the treatment of all patients with multi-drug resistant TB in this case. And then we just leave this open, whether it's a stronger conditional recommendation, either for or against, as you can see. And sometimes, because indirectness ratings may influence the overall quality of the evidence, we sometimes don't pre-specify the quality. Now, just a few final words why we need to be clear in terms of how we formulate recommendations. It becomes a very, very, very important issue in our view, and there's always a lot of debate about this. There is actually evidence that guideline groups have not been doing a great job in terms of formulating recommendations. This is from Rick Schiffman's group, from Yale paper from 2009. They actually looked at the ARC Guideline Clearinghouse, guidelines.gov, identified 1,275 recommendations randomly. They found huge inconsistency across guidelines as well as within guidelines in terms of how they were formulated. About a third did not express the recommendation clearly. Most of them were not written as executable action items, and that's just to reemphasize that we really should be doing this. Over half of them didn't indicate any strength. So that is really important, in my view, important evidence that we could be doing much better in terms of formulating recommendations. Just thought to provide you with another example of how a recommendation could be formulated, how we do this, and how it's actually recommended in the ACIP in Farouk's ACIP document, which is for stronger conditional recommendations. Oh, actually, this should read suggests. Apologies. For strong recommendations, we use the wording recommend. For weak recommendations, we can use the wording may or suggest. And for recommendations against, for strong recommendations, we would recommend against or suggest to not use it. So one example, additional example is the guideline group recommends rapid DST testing for resistance to INH and rifampicin, which are TB drugs, or rifampicin alone over conventional testing or no testing at the time of diagnosis of TB. Conditional recommendation, low quality evidence, or 2+ quality evidence, and then values and preferences. A high value was placed on outcomes such as preventing death and transmission of MDR as a result of delayed diagnosis, as well as avoiding spending resources. So just a brief explanation in terms of the values and preferences, and that the values and preferences came from the guideline panel. Hard to read, and just to explain to you that we've now moved even further when we provide these decision tables. So based on these experiences with the TB panels and so on, we've realized that we can provide narrative information to make it even more transparent. I'm not saying that this needs to necessarily be done all the time, but it helps with working through the issues, in particular with complicated panels or difficult panels, where we summarize the quality of the evidence, provide key reasons for down and upgrading in a narrative format for people who have difficulties with evidence profiles. I want to see it in a narrative format. We provide information about the baseline risk for benefits. Is it similar across different subgroups of patients? Should there be separate recommendations for subgroups so that groups are actually considering this? Then what the perspective taken is for the values and preferences, usually patients, but it could be obviously society. The source of the values, so is it from the guideline panel or is it from the literature that was assessed? The source of the variability, if there is anything, and then the methods for determining values, and whether it was satisfactory. So is it considered satisfactory that the panel actually provides the value and preference statements, or do you need to go, or should it have been the literature? And then cost of treatment, we are dealing with feasibility issues as well as opportunity cost, and whether there are differences across settings. This just to, because these are the decision criteria, this just to enhance the transparency around formulating recommendations. It is 2:55. I would stop here, but these are the decision tables that lead us to make recommendations. I would stop here with this presentation and just take questions. If there are any. If there are none. Yeah, I know it is hard to read. So the third column says this is a summary of the reasons for the decision. So in other words, we are asking panels to make a decision about whether the quality of evidence is high or moderate, which would lead you to would make you more likely to offer a strong recommendation. The next question here is balance of benefits versus harms and burden. So is there certainty that the benefits outweigh the harms? So this would say yes. And then here it would just provide a brief narrative description that there's considerable benefit while very little clinical harm or downsides are expected. And the same is true here for the values and preference. So the benefits are much higher value than the expected minor harms, and to provide a brief explanation. So as you think of this as a unfolding explanations where it becomes more detailed as you move from left to right. Yes?
So I have a sort of practical question, probably for both you and Farouk. Since we're just getting started with this in ACIP, I'm not quite clear yet on the actual format of what the recommendations from ACIP will look like, whether published as brief policy notes in the weekly MMWR or as full recommendation and report statements. And I'm just curious in practical terms of what kind of tables do you generally end up including for readers, whether they would actually be published in the body of the recommendation or, I think as SAGE does, as online links.
Or do you want me to take I could tell you what we've been doing with WHO
I mean,
and various other groups.
Like, for example, I'm not sure, is this a kind of table that would be presented to the reader in the end, or to the user?
This is probably one of the tables that we would put in the online repository, so for people to see, or that we would put there for those who want to understand the rationale for a recommendation to go through. The work that we've done in terms of what people really want to see probably is more so we haven't assessed whether people want to see this necessarily, but we do know that they want to see the summary of findings tables when you present the recommendation. So either the full evidence profile or an abbreviated evidence profile. But we provide this as for reasons of transparency in appendices. Sir, did you have additional thoughts?
Yeah, I think what we put in the vaccine paper, I think most people would want to see that information. So anything additional details, we can think about where to put it.
Yeah, so
Slides that you have shown were very, very condensed
Yeah, I think it depends on your situation. If you think this will help them in making a decision, then you can, write it out. Not all ACIP members may understand all that statistics and numbers.
Yeah, so sometimes these narratives, once again, help panel members understand better. We need the tables in order to make the quality assessment and have a numerical estimates, but sometimes the narratives just help them to make informed judgments. So where this is probably a stage in between. This is it's hard for you to see, but if you actually sit in front of it, if you have it in front of you, it helps the chair of the panel to actually move through the issues relatively quickly, because you can say, okay, for this recommendation, what is the quality of the evidence? The quality of the evidence is high. Remember that when you make a recommendation. Balance of benefits versus balance of benefits versus harms and burden. So under those circumstances, he could just quickly say, remember, there was some big mortality reduction, there was not a lot of adverse consequences, so it looks like the balance is clearly in favor, which is a yes. So it helps the process along. In terms of publishing it, you can put it in the background, or you can make it your main table. We don't really know what works best.